Good afternoon. My name is Angel Palermo. I'm the Associate Dean for Diversity and Inclusion at the Icahn School of Medicine at Mount Sinai. I am also the moderator of today's session, and I would like to welcome you to part 2 of today's session, the Medical Student Perspective webinar. Next slide, please. So again, thank you for joining us today, and hopefully over the course of the week. Before we get started, I'd like to acknowledge an additional session that has been added, Racism, American Medicine's Fatal Flaw, on Friday the 12th from 6 to 7:30. As educators, physicians, students, administrators, and staff, we are all facing difficult conversations as this country reckons with its past, present, and future. We hope to bring a space for further these conversations. So, in light of this incredible stress so many people are facing, let's do a quick check-in using Slido. So Slido is the main format of communication for us throughout this week and for today's session. For those of you unfamiliar with Slido, you can go to slido.com on your computer with your phone using the camera to hover over the QRS code, which will ask you to open in a search engine. Using the summit, #summit, you will be taken to a poll. There are 2 sections to the polls and Q&A. So for now, choose polls and reply to the poll with one word that you're feeling in this moment. So we've got folks, hopeful. A lot of people feeling hopeful and exhausted, absolutely. That personally resonates with me. Tired, others are feeling overwhelmed and eager, but ready, energized, cansado. All right, I think that's our first bilingual response. Appreciate that. Beat, eager, sad, uncertain, drained. But it's awesome that people remain hopeful during this time. Great. Intrigued, zoomed out. Yes, I think we can all relate to that. Great. Thank you for indulging me in checking in and sharing how you're feeling at this moment. Okay, so I would like to highlight the collaborative of the medical schools in New York and New Jersey in organizing, delivering this conference. There are a lot of great, obviously we've been experiencing a lot of great content and discussion thus far that we've had this week. And so it's really a result of these efforts. In addition, we want to thank the AAMC, the Macy Foundation, and AMS New York for their support and collaboration. Next slide, please. So these are the Subway Summit learning objectives. This conference was really designed to share the experience of medical schools from the front line. So here are the objectives listed here of overarching goals of the entire conference. And these are also tied to receiving CME credit for your attendance. So if you wish to receive CME credit, you must be either registered or on the wait list, and you can email cme@mssm.edu. Next slide. Part 2 today, though, is really to focus on the voice and experience of our medical students. So through formal presentations and in breakout room discussions, which will be student-led, you will hear about key facets of the medical student experience during the pandemic, various approaches and responses to address medical education needs through the lens of the student, and hear what worked, what did not work among these approaches, and what factors should be considered in the future. Next slide. These are today's presenters. As you can see here, we will hear from a cross-section of medical schools and their respective students. So we'd like to check in one more time and get a sense of who's with us today and what is your role. So if you could use Slido once again and respond based on the choices listed here. All right. So clearly the students are here. Okay, so far, we've got about 70% students among the 20 or so respondents. Okay. About 30% have a role in making decisions that impact students. About 7% mentor students, about the same teach students. A smaller category of other, okay. Great, so it's really great that students are here to hear with each other, as well as individuals who make decisions and are also critically important to the student experience. So thank you for responding to the poll so we have a sense of who's in the room. So we also want to find out in one word, what made you attend this session today? See what, to learn, absolutely. Learn from each other, curiosity, yeah. Perspective, need to learn, support, inform. Feedback, excellent. Development, critical to hear from students, absolutely. The care for students, humility, doing better at supporting student needs, advocacy, respect, perspective, critical to hear from students, curiosity, support. Students rock, high five on that response. Absolutely. Hear about the student experience, perspective, and the need to learn. So we recognize and that we're all here to learn, to support, and learn from each other, of course. Great, thank you for indulging us once again. Okay, so let's turn to the students. So the way this is going to go is that there will be formal presentations from 4 different schools from that will end approximately at 6:10. At that point, we will share with you a slide that will then take you to the Zoom links for the breakout rooms that you can choose to participate in. So with that said, let's turn it over to the student voice. First up, our colleagues from Columbia. Please go ahead.
Thank you so much for that amazing introduction. My name's Sarah Sue, and I'm here with Sibel and Sam, and we're so excited to be presenting our student volunteer corps at Columbia. Next slide. This all started really for us on March 8th, when all in-person classes were canceled at Columbia, and then a week later, all students were pulled from clinical duties. At this time, I met with Dean Amiel, who's our Dean of Medical Education, and 2 faculty members, in addition to another medical student, to discuss how we could actively contribute to this COVID-19 pandemic, because we saw how much the hospital system was really hurting. And within 3 days, we actually rolled out the COVID-19 Student Service Corps. You can go to the next slide. When creating this organization, When creating this organization, we were very mindful that as New York City residents, we were being hit not only the hardest, but first. So we use this as an opportunity to really be mindful and create an organizational infrastructure that could also be replicated at other institutions that may have not been affected yet. So what we did is we created this toolkit really to serve as guidance for other student service corps to create and help support volunteer efforts going on. And you can go to the next slide. The response was overwhelming. So at this point, we have more than 1,800 students across 12 different Columbia schools and programs. And it became extremely clear that recently sidelined students were itching at a chance to join against, these COVID-19 pandemic, and were willing really to participate in any capacity that they could. And what we did was we were able to provide a means for them to channel their energy and pair them up with opportunities that would allow them to accomplish this goal. We have more than 20 ongoing projects, and I'm going to hand it over to my fellow co-chair, Sibel, to discuss.
Hi, everyone. So I'm Sibel, and this is basically a chart of our organization. And so me, Sarah, Sam, George, and then 4 other faculty members, we're part of the oversight committee. And then this just shows that we have all of our projects kind of broken down in who they're serving and interfacing with. So we kind of categorize them by the patient and system facing projects, where really are about supporting the medical system and making sure that patients are getting the care and the support they need in order to navigate it during this time. And then we also have our staff and student facing projects, providing the support to the school, to the staff members, and even down to tech operations. And then we also have our community connections, which were really more about making sure that people are getting services like meal support, tutoring, and also child abuse prevention. Next slide, please. So we just wanted to highlight some of our projects that we were really excited about, and these were kind of the ones that started everything off. And so 2 of them were telemedicine and the community hotline, and these are both patient and system facing, and they were really both created in order to decrease strain on the healthcare system, both in terms of follow-up with patients. So the telemedicine remote patient monitoring project basically helped provide follow-up care to COVID positive patients that had been discharged until they had recovered fully from their symptoms or had been bridged to follow-up care. And through this program, we were able to reach out to 890 patients, and they were contacted, they were followed until they were seemed to be stable and not need more support, or bridged successfully to more care. And with the community hotline, this was really offloading the project from 40 PAs that were running the hotline in order to let students basically answer calls and help inform the community, anybody who called in, get information about quarantine instructions, what was going on with COVID, when they should seek medical care, and all of those other things that were really important into helping people navigate the situation and making the best decisions. And with that project, we answered 5,500 plus calls and just really disseminated a lot of information. Next slide, please. And so then 2 other projects, we had an OB outreach and postpartum follow-up project. And this was 2 things. It was outreach to prenatal patients in order to give them education about, going to appointments, what to do to protect themselves and, their families. And then also we had postpartum follow-up that was really in response to the fact that there was very quick turnover in the hospital during this time. And so people were being discharged after giving birth a lot faster than they maybe would have otherwise. So that was calling to make sure that, there weren't any red flags, that they had all the information they needed, and just kind of giving more information and support to these patients that may have felt like they were, rushed out of the hospital or didn't know who to contact at this time. And with that program, we contacted over 2,250 patients. And the 3 projects that I just talked about, what was interesting about those is they were really the only projects that we found that really required clinical medical students. And we found that a lot of people, when making projects, thought they needed clinical medical students, but when we actually looked at the projects, there were really only these 3 that required clinical experience, and the rest gave us the opportunity to really look at interprofessionalism and work with public health students, physical therapy students, occupational therapy students, even undergraduate students, and just kind of bring all the students together because their passion and interest in serving the community and the healthcare system at this time was really the most important thing in terms of their volunteer involvement. And so Hero Meals was another project that we had that was really about providing meal support to frontline healthcare workers through partnership with local restaurants and catering services. And we provided meals for 9 hospitals, raised $240,000 and provided 20,000 meals. Next slide, please. So some of our staff and student facing projects focus more on kind of information and education. So our information services project was really focused around doing literature searches and kind of consolidating this information so it was easily accessible for healthcare workers and staff and students at the institution. And then medical education was addressing kind of the interruption in medical education that was caused by the pandemic. And so it was also, offloading a lot of the responsibilities from our clinical faculty members who had to be, in the hospital and didn't have time for some of their educational duties, and getting students, upperclassmen, involved in kind of transitioning some of those workload in terms of small groups and tutoring, and then just kind of moving towards this virtual education mode that we all kind of knew was going to be necessary in the coming months. Next slide, please. And this just kind of is here to highlight some of the interprofessionalism that I had mentioned. And so at the top, you can see these are all the different schools that we were working with. And some of them are clinical. We had dental medicine, nursing, obviously the medical school, PT and OT, but then we also had engineering, we had nutrition, we had mailmen, our public health school, the graduate schools, and the undergraduate school is a partnership that is a little bit newer, but has given us a lot more volunteers. And they're pretty well distributed across the program. There are some that needed that clinical experience, but there were really a lot that didn't. And that was a really cool thing for us to work with in terms of making those partnerships. Next slide. And now I'm actually going to turn it over to Sam, who's going to talk a little bit more about the other components of our organization.
Thank you, Sibel. Good evening, everyone. My name is Sam Burnham. I'm one of the co-chairs here today, and I'm going to pick up right where Sibel left off to talk about service learning and how that really has been an exciting piece of this. The CSSC are many projects, and a lot of the learning that takes place has weaved into an already very robust fabric within CUIMC that fosters service learning, to the point where we've actually been able to use engagement in these projects as elective credit for some of our students across the graduate schools. Now, service learning, many of you have chapters that focus on this, but the basics are that students are presented with thoughtful prompts, research, engagement in different sort of educational materials to prepare themselves for actually engaging with whatever service piece they happen to be with. They then take a moment to reflect and consider how they've been participating so that they can rehash, reflect, and hone that to be more effective and perhaps make that engagement a little bit more robust. So if we could hit the next slide, please. And so this is sort of how we break it down over at CUIMC, is that we have these weekly reflections where preceptors are leading interprofessional groups across the schools where students can debrief and process what they've been experiencing in these different projects and groups. Whether it's a challenge or a particular victory, they're given the chance to reflect and engage with one another. As I mentioned, at the Vagelos College of Physicians and Surgeons, students will actually get elective credit for this. And it also has really fostered some outstanding interprofessional ties across some of the graduate schools, which I'll talk a little bit later, a little bit more about. So next slide, please. So what did we learn? Clearly, this has been a Herculean effort on the part of every single graduate school and so many different people, faculty members, practitioners, and community members. Well, I think this will be echoed by other groups, but the COVID-19 pandemic truly accelerated processes that really have always been there. One of the keys to the success was this interprofessional engagement in education. And what we found was that in a time of crisis, these groups started to talk to each other a lot more. People were eager to bridge gaps between schools that were once across the board very isolated. I think one of the things that we're recognizing is that the CSSC once stood for the COVID-19 Student Service Corps, but very quickly we're going to change that into the Columbia Student Service Corps. There is going to be a space for this well beyond the pandemic to amplify and augment the voice of students during crises of all sorts. I'll talk about one group that's really taken charge in that sense shortly. And this crisis has flattened traditional hierarchies. That is, students are engaging with administrators, faculty members, leaders in the community, all to really reinforce these efforts. And it's been quite remarkable to see these connections that are built. So we can proceed to the next slide. So moving forward, I think Columbia is starting to recognize that as COVID-19 cases decline, CSSC has reached a key inflection point in the way we're going to be moving forward. We want to shift towards supporting sustainable longitudinal community projects, fostering this network of partnerships to keep it moving forward. And we want to develop and nurture this sustainable infrastructure so that interprofessional education across these different schools can continue forward into perpetuity. We want to integrate these services into the VP&S curricula, as we've seen that this takes a really unique role in giving students this elective credit, but also a real opportunity to engage where there once was sort of we could call it a black hole in the wake of the pandemic. Next slide, please. And so that leads to some of these other projects, these community-facing projects that form a pretty prominent arm within our overall architecture. Moving forward, I'm going to talk about a few groups that are here to stay, I think. Learning Together is a virtual one-to-one tutoring program for children in Washington Heights and the Inwood area that will likely continue well beyond the COVID-19 crisis. In a lot of ways, that was just the catalyst to get this started, but that these students will continue to need that. Chalk, a group that helps register food insecure families for food distribution, has established a really robust system that will continue forward for those families and moving forward across the different graduate schools at Columbia. Next slide, please. And I think one thing that I'm particularly proud of as a co-chair is Mask Check. You know, as I mentioned, the CSSC was founded during a time of crisis, and recently, we're finding ourselves at a boiling point of a chronic and ongoing crisis. Mask Check was founded to provide and coordinate the distribution of handmade PPE to at-risk patients, incarcerated folks, folks in homeless shelters, and now they've shifted a lot of their work towards protesters and providing masks for protesters in the wake of the murder of George Floyd. And since then, since they've shifted, we've had over 5,000 masks crafted and donated to at-risk patients. And they were actually featured in an article in Vogue recently, just showcasing their flexibility and adaptability. That's not unique to Mask Check. I think that is a characteristic across the board for all of our CSSC groups that really makes them remarkable, and I think is going to be so important moving forward in that line of sustainability. Their adaptability and flexibility during a time of crisis is what's going to make this last and be a meaningful contribution to curricula throughout all of these different graduate schools. Next slide, please. And so that really wraps up our discussion today. Thank you all so much for attending. You can see some of our links here to our social media accounts. We encourage you all to follow those. But at this point, I'd really love to hand it over to our colleagues at SUNY Downstate to talk about their experience during this crisis. So thank you all so much for listening.
Thank you very much, Sam. Good evening, everyone. My name is Jonathan Leong, and I'm here with my colleague, Anjali Jaman, and we're both fourth-year medical students at SUNY Downstate. We're both honored and excited to have been invited to speak with you today, and hope that you'll come away from our shared experience with some pearls that you can implement at your home institution. Next slide, please. So to set the scene, my class was 1 month away from finishing our third year when COVID-19 hit New York City. We had just finished finalizing our fourth-year schedule, and our junior colleagues 1 year below us were about a week out from taking their step one exam, which for those of you who don't know is probably the single most nerve-wracking test that you'll take during medical school. Their test was suspended, and our class was subsequently pulled from rotations to prioritize our safety and to conserve PPE. And while this was anticipated, it was still very surreal to transition from reading about the disease halfway across the globe to having it land at your doorstep. We went from aspiring surgeons and neurologists to audience members watching the scene unfold before us. It was apparent within the days leading up to our exit that our hospital would need our help, and that speed was of the essence. We were pulled on a Friday, organized over the weekend, and by midweek, we had met with our deans to discuss our safety and with hospital admin to assess their needs. Within a week, we had implemented student design projects that were founded on the skill sets that we had developed through our clinical training in under-resourced hospitals. Next slide, please.
So the scope of our work is pretty broad. We provide support in the form of data collection for daily huddles, food and PPE donation testing protocols, which students help develop and execute in our labs. We provided non-medical support for our patients, linking homebound elderly people with community-based organizations to deliver medications and food to sustain them during the lockdown. We also delivered a lot of COVID test results, both through HHC and through our hospital, and also kept families updated about the care of their loved ones when they weren't allowed to visit in person. And although we weren't essential workers, we became essential during the response. Next slide. So the projects we created came from patient needs, from gaps in the healthcare delivery system that were exposed and were magnified by when our hospitals were pushed to their limits during the crisis. As more data has been published by various institutions across the city, we have come to realize, obviously, and we all know this in New York City, that the pattern illustrated resembles the previous state of affairs in New York City. As downstate student, we often look at maps like this. The first map is a map of wealth distribution in New York City. The second is a map of racial segregation. The third map is showing significant life expectancy inequalities across different neighborhoods. And we know that these inequalities are driven by racism, by socioeconomic inequalities that map geographically onto our city. And obviously, unsurprisingly, we see that COVID inequalities, including testing, cases, and also hospital availability, which is the last map here, locations of hospitals and beds available map onto the same neighborhoods. Next slide.
Students had a role to play because there was a crisis, but students have always had a role to play because there's always been a lack of healthcare resources available in certain neighborhoods and for certain members of our city. And it's just a much slower moving crisis.
So all of our projects have this feeling of addressing a pre-existing inequality, but this is a snapshot of one project that shows this dual centering of student education and addressing inequalities and seeing them as linked. So students independently developed a needs assessment based on validated social determinants of health tools that were pre-existing in literature and created a 40-page manual, actually. And they approached faculty members with this assessment and the structure for implementing it. And they gained support from faculty in a variety of primary care clinics in our hospital. Altogether, this project has surveyed 3,400 patients from our primary care clinics about needs that they have. And here's some of the data that was collected from one of our clinics, our family medicine clinic. We can see that students have had a profound impact on actually linking patients to the services they need to survive and thrive right now, and that the education around social determinants of health historically, usually in our schools, focuses around learners through well-defined learning objectives and doesn't focus on patient-centered outcomes. And there is evidence that this kind of passive learning doesn't actually prepare students to act against structural inequalities, and in fact may lead medical trainees to just accept these inequities as facts, rather than as points of intervention. And I guess overall, this just represents our feeling that student responsibility and student learning are a bi-directional relationship, and they can help guide the priorities of our healthcare system. In general, students have always had the potential to contribute to the healthcare system, and even in this early stage of their career. Next slide.
So we were revitalized by our work. We regained a new vigor for our patients, strengthened our bonds as classmates, and even evolved our relationships with our faculty members. Our commitment to our patients and the confidence that we displayed was appreciated by our deans and expanded our collaboration with them beyond just crisis response. As the curve flattened early May, our focus pivoted. Drawing inspiration from our colleagues throughout the city, including up at Columbia, we prioritized creating academic credit for student work done during the pandemic, working with faculty who had advocated on our behalf to create several student-designed non-traditional electives. And at first we struggled with this a lot, since so much of what we were doing didn't necessarily fit within the pre-existing model of medical education. And while what we were working on wouldn't show up on a multiple choice board exam, the skills that were being developed, such as understanding the social work surrounding a successful patient discharge and developing and implementing telemedicine, would help students not only during their residency, but also later on as attending physicians when patient health outcomes and their actual health becomes more important than your board scores. And it wasn't actually until a MA webinar from the students and faculty at Penn State about value-added education that we really find a solid concept to build upon. And we would like to once again thank them for taking the time out to speak with us about their work and their experiences. So what value-added education does is emphasize experiential roles that have the potential to positively impact individuals and population health outcomes, cost of care, or other processes within the healthcare system, while also enhancing student knowledge, attitudes, and skills in the clinical or health system sciences. This concept gave our projects a home within the pre-existing meta structure as our work fulfilled criteria under the systems-based practice domain, one of the 6 core competencies fulfilled by which the LCME evaluates medical schools. Next slide, please.
So as the peak of the pandemic has passed New York City, we've been working with senior faculty and hospital administration to transition many of our projects into more permanent homes in our hospital and our school. And that has to be done because they address pre-existing inequalities that are still relevant and are going to continue to be relevant. The COVID crisis has made it clear that the existing healthcare system does not work. And it's also made clear that adopting this structure of really supporting students and giving them a space to lead can fundamentally change the way that medicine operates and improve our patients' well-being, our hospitals, and our educational system. Most students feel a pretty deep sense of ownership and responsibility about their projects and are working on actively transitioning them. And one example to highlight this is the community-based organization management. That was a project in which students called over 170 Brooklyn-based organizations to assess what services were available and to build partnerships to meet the needs of the community in Flatbush. And we've conducted also routine follow-up through that project. After an initial referral was made to a community-based organization, we followed up to make sure that that individual patient actually received services in order to close the loop and address any additional needs. But in our follow-up, we kind of found out that patients benefited from these services and have been, and this is an area of improvement that we need to address in direct partnership with the hospital. And as a result, now students are working on implementing a community advisory board at SUNY Downstate. It's a project that they're kind of developing and thinking out. And an empowered and well-integrated community advisory board actually could have a tremendous transformative effect on the relationship the hospital has with the community. Next slide.
And finally, we have established a close partnership with the educational leadership in our school. Now, this started off as like a natural progression of the work to transition our telemedicine project into the clinics and adapted for the core clerkships as a mean of providing students with patient exposure while also abiding by social distancing and public health guidelines. What it has evolved into is a partnership with clerkship directors that expands just beyond telemedicine. As illustrated on the screen, we hope that this partnership is beneficial to both the clerkship directors as they have additional help with planning and additional avenues of feedback, and for the current seniors that are working on implementable medical education projects. And our long-term goals for this partnership is to serve as a model and a catalyst for changing the culture surrounding student involvement at our school.
We believe that student co-production can help drive our healthcare system to greater innovation, efficiency, and justice. And we need to keep this in mind. I think some of the lessons that were learned during this COVID response are going to be applicable right now as hospitals and educational systems are called on to face anti-Black racism, both in our societies and in the hospitals that we call home. Students often have great insight into how racism manifests, how it impacts students, how it impacts patients, and supporting those voices and letting students lead in this issue, I think also is going to help pave the way for a more equitable healthcare system. We hope that a permanent collaboration between students, educational leadership, hospital administration can help deepen the integration of the educational aspects and the patient care goals of an academic medical institution. And we hope that all stakeholders can come together in a long-term way to view these partnerships as crucial to the development of future generations of healthcare providers. Thank you for listening, and we're happy to talk with anyone if there are more specific questions, but we're going to pass it on to Mount Sinai now.
Hi, everybody. My name is Benjamin Liu. I'm a fourth-year medical student here at Mount Sinai, and I'll be introducing some of the medical student perspectives from here as well. So initially, we just want to talk about the overall timeline of the things that happened at Mount Sinai. I think the big things that I want to highlight here is not to get bogged down by the individual details of this slide, but the different perspectives and the changing ideas that people believed as well. So on March 1st, as mothers have mentioned as well, the first documented case of COVID in New York City, and just 2 weeks later, we had our clinical rotations canceled. Like many of our colleagues across this call as well, the medical students rose to the occasion and answered a call to help our Mount Sinai health system. I think this period of change from March 1st to even to the middle of April as well is mainly focused on the perspective that students felt like they needed to do something. Our health system in our community was being burdened by coronavirus, and we thought that we could do something to change that as well. I think a lot of us, medical student-wise, came here not only to be physicians, but to become advocates and leaders as well. And this was an opportunity to help not just the community, but to our health system as a whole too. A large changing point for us was also on April 11th, where the daily COVID positive cases in Mount Sinai actually declined for the first time. And from that point forward, I say we entered this phase of student perspectives that we call a phase of feeling things were out of control. Not just from the COVID crisis as well, but in a sense that a lot of things were happening out of our control. Medical school seems to be a thing where you make each milestone, and those milestones are set in stone. You finish first year, you finish second year, take step one, take step two. Now we're facing these challenges where a lot of my peers and a lot of my peers across all institutions really experienced these seemingly random NBME cancellations from our tests. These steps, step one, step two, these tests we're studying for and preparing for years and months at a time are now up in the air. And that's not anyone's fault per se, but it just represents some of the frustrations that we faced as medical students and some of the things that we really couldn't change. I think something that really helped during that process though was partnering with the medical education and the administration in developing ways for us to cope with those changes as well. Throughout this whole process, from the beginning of day one for the clinical cancellations, we're talking with medical administrators about rotation makeups, about the step examination changes, and about even preparing to go back to the wards. How will that look like? How can we impact that change? And how we can logistically support each other during that moment too. Finally, where we are now with the Black Lives Matter movement, this global movement that erupted in the beginning of June, I think students have a particular strong voice. And I think we have a stronger confidence that our voices can be heard and that we do have a moment for them to be heard as well. From our initial experiences volunteering and supporting our healthcare system, we now feel like we're not just physicians, we know that we have places and we have a privilege being possible physicians in the future, and for the fact that our voices do have a say and they do have a matter as well. But in addition to that, I just want to talk a little bit more about what Rohini was saying and really the frustrations that we as medical students were facing. She was mentioning a story that one of my colleagues was having where step one, he had planned for early June. It was canceled once and he had to reschedule for 2 weeks later. He had canceled another time. And now at this point, he's wondering when he's going to be able to take it. It's just a story to encapsulate kind of the frustration that we're all feeling, especially during these times where we used to think that we have things that are set in stone. We'll take step one, we'll take step two, we'll go on residency interviews, we'll fly across the country and do all these things. But now we have to pivot and just find where the things are changing and how we can adapt to them as well. We'll just move on to the last slide here. And so this number 27,000 is just a number that we wanted to show you about the overwhelming amount of work that we've done for the past 9 weeks here at Sinai. We didn't talk too much about the actual projects that we've been doing, but these are the number of hours that are associated with them. And we'll talk a little bit about the reflections that students have had during this period as well in the next slide. So in our student volunteer form, we have a question at the end of each week that we want students to answer. The question's listed here, and students were asked, what was the most interesting part of your volunteer task this week? Something, for example, might be an interesting task, a clinical conversation, a memorable experience, or anything you'd be excited to tell your friends and family about. As our other colleagues had mentioned, service learning is an important part of medical school, and I think sometimes tend to forget that. Here we have an opportunity for students to reflect on the different tasks that they've been done. I won't read the actual quotes here, but from these quotes and from these experiences, we've developed ways to move forward in some buckets that we think are very important, not only for us now, but for the future as well in incorporation to medical education. Firstly, we wanted to have an increased source of mental health resources for all students and for all faculty, especially during these unprecedented times. And I think something that's really helped, and I think that's really been helpful for all the institutions across the board, are that we've developed closer relations between medical students and the administrations. I think before, there were student advocates and there were people who were involved in medical education, but the closer that we are, the closer our goals and values can be developed. I think the better things are in the future as well. I think one of the also most important things that us medical students have developed is empowerment for students and an idea that we have voices and the advocacy is part of our learning as well. A lot of us apply to medical school and we have all these things on our extracurricular activity sheet, things about advocacy, things about volunteering, and things about leadership as well. Sometimes I think those things get lost during clinical rotations where we really don't have that much time or that much extra time to dedicate to these causes. And I think this time has helped us develop a moment of clarity and a moment of response to continue developing those skills. Being a doctor is not just about treating a patient, but it's also about how those things outside the hospital affect those patients' livelihoods. Next, I guess, as all the other medical institutions have mentioned as well, is the student role in medical education. Particularly for us here at Sinai, telemedicine is going to be a big part of our curriculum. And because medical students have developed at least some part of the learning, we are having a big hand in shaping what that medical education will look like in the future as well. Finally, I think the most important thing is supporting each other in these times of crisis. And I think despite the social distancing, despite the physical distancing that we've had to do over the past few months, a lot of my classmates and a lot of our peers have come together to make things even closer. And I think these times of uncertainty bring out aspects of ourselves that we don't usually get to share with each other. Next slide. And finally, this is just an example of things that I think we can move on and carry forward as well. Medical students need to have a voice and a hand in designing future curriculum at all levels in the medical school, and then even in overarching structures like the AAMC and BME and LCME as well. I think we medical students during this time have realized that we do have an impact. We do have a voice and we can make a change. I think this is one of the first instances where we have actual concrete evidence of that too. I hope that those things and those lessons aren't lost in the future. And with that, I'll pass the last of the presentation over to our colleagues at Einstein. Thank you.
Thank you, Benjamin. My name is Rachel Weinstock, and I will be joined by Anna Bittners, Brian Zeglin, Christopher Itzwa, and Mitchell Veith. Next slide. We're going to walk you through the experience of student volunteers at Einstein during COVID, how the crisis in the Bronx and our hospital system accelerated involvement of already concerned students. We will share how this firsthand experience in volunteering became one of community-based learning and social justice, which has lasting educational value. And finally, we'll propose a way forward for medical education. Next slide, please.
My name is Mitchell Veith, and I'll start with our context. So to understand our COVID story, it's important to understand our context. As Einstein students, we've either come from the Bronx or quickly become familiar with its people as we learn. The Bronx's history as a diverse working class borough makes it a place that we're proud to be getting our medical education. Next slide, please. One thing we grapple with as Einstein medical students is the health of the Bronx population. Over the last decade, the Bronx has consistently ranked 62 out of 62 New York counties in health outcomes, life expectancy, and other measures of general population health. When COVID-19 spread began in New York, healthcare workers in our communities quickly realized the implications. To date, the Bronx has the highest population mortality rate from COVID-19 across the 5 New York City boroughs. And healthcare justice has been a calling of many of the people in the Bronx for a long time. We believe understanding this history is key to understanding Einstein, as well as why volunteerism quickly emerged to address issues like healthcare disparities, food insecurity, and language barriers to information dissemination, to name a few.
So what is the Einstein story? Einstein's long history of advocating for community involvement attracts students who see service and social justice as integral aspects of their professional development. Prior to the onset of the pandemic, the Community-Based Service Learning Office, Office of Medical Education, and Student Activities Office coalesce around these values, which make the Einstein student experience so unique. of organizations such as the Einstein Community Health Outreach student-run clinic, which provides free primary care services to uninsured population of the region. Currently, about 80% of the first-year class volunteers at ECHO, or the community clinic, and many students continue to participate throughout their time at Einstein. Additionally, 12 programs sponsored by the Community-Based Service Learning Office provide opportunities for students to engage and learn with the Bronx community through mentorship and patient advocacy. Lastly, our population health course at Einstein, during this course, students build the skills necessary to critically evaluate public health research and advocate for structural change to driving force for us as students is the community of the Bronx, which motivated students to get involved. Next slide, please.
In addition to our community and students, a third component which facilitated our engagement as volunteers was the support that we received from our Einstein administration. Clerkship at Einstein typically use a tiered grading system, but this was switched to credit fail system during COVID, and that gave students the flexibility to dedicate extra time to volunteering. Also, a variety of offices on campus support our students by providing faculty mentorship, helping implement major programming, and also assisting with our transportation needs to volunteer opportunities. Lastly, our fourth year schedule was adjusted to allow for early graduation, and many fourth year students opted to graduate early in order to join healthcare workers at Montefiore in providing clinical care to patients with COVID. Next slide, please.
What was going on through the minds of some of our students as the pandemic quickly unfolded around them? A quote from a student leader: "I saw an opportunity to contribute and fill a need that had yet to be filled in our Einstein Montefiore community. As a first-year medical student, I was close enough to the front line to have a considerable understanding of the hardship faced by our frontline workers, close enough but unable to contribute on site and assist in a way that seemed tangible. Or so I thought." Next slide, please.
Now, soon after clinical education went virtual, our students began to carve out their role in the pandemic, where they would contribute well over 10,000 volunteer hours while still actively engaging in full-time virtual clerkships. So here we have our institution's unique COVID-19 patient census, and each one of these lines represents a different rollout date for a different volunteer activity that was started at Einstein. Next slide, please. Now, early in the pandemic, most of our volunteer activities indirectly benefited patients by supporting our healthcare system. To highlight a few activities, our students started a childcare and pet sitting service for healthcare workers. They also staffed an occupational health services call center where students would talk with employees who had potential COVID-19 exposures. Our students also secured PPE donations and led large-scale manufacturing efforts at our institution. And we also had students working in staff support centers to provide mental health resources directly to healthcare workers in our hospitals. And all of these efforts were student-led and supported by our student-run COVID-19 Einstein response team. Next slide. Now, later on, as our healthcare systems and our patients' needs changed, students began to take more direct roles in patient care. On the inpatient side, we had sub-interns working on COVID wards directly. And other students worked with the infectious disease and renal services to provide inpatient e-consults to medical teams. On the outpatient side, our students launched telehealth programs at both the departments of family medicine and internal medicine, and briefly worked with a COVID discharge clinic as more patients required follow-up after returning home. And in addition, our harm reduction and addiction medicine group supported patients at local methadone clinics, and we launched a grocery delivery service for patients experiencing food insecurity. And finally, we work to provide infant survival kits for newborn mothers who have had difficulty acquiring formula and diapers during COVID. Next slide, please.
As the curve began to wane, students were still engaging in volunteer activities, these now focusing on external community support. A student leader of the Infant Survival Kits project describes, "COVID-19 has affected our Bronx community disproportionately, not only in the higher incidence and worse clinical outcomes in the hospital, but also in the deep financial insecurity from a greater proportion of jobs lost, independently impacting our patients and their families' health. The pandemic exacerbated disparities that have always been here. While my volunteer experience did not involve direct patient care or clinical work, it was meaningful and important to alleviate some of the financial burden for our new moms and dads. We as student organizers see an opportunity for medical education to greatly strengthen itself by way of this connection that students feel to the community, their schools, and the hospital system." Next slide, please. One clear example of an opportunity to strengthen medical education in a community-responsive way is through telehealth. It is a new and rapidly deployed volunteer activity that has alleviated pressure felt by both providers and community members when slammed with COVID concerns, while calling patients, students, and volunteers and their preceptors at Einstein could not ignore the social needs, both old and new, which directly impacted patient health. Student telehealth is an opportunity. Our family medicine department began social determinants of health screening project through our COVID response to connect all our patients with critical social services, including, for example, a student-run grocery delivery service for food insecure patients. However, telehealth itself has a slew of major disparities: advanced age, low-tech literacy, little to no access to devices, all of which disproportionately affects Black and Brown folks. Telehealth is already on track to be a major part of the medical curriculum this year. Curricular design must be intentional in ways that embrace telehealth while critically examining it. Otherwise, we as a medical community will exacerbate the disparities that we already see. Next slide, please.
As students and as an institution, we're now beginning to reflect on our experience. What good can we harness and carry forward into the future of medical education? Over the past few months, students have learned about community organizing, witnessed how social determinants of health impact our patients, and organize efforts to mitigate their effects. Behind these invaluable educational experiences are 3 core values that we think should continue to propagate in the post-pandemic landscape and help guide medical education reform. 1, community should be at the center of medicine. 2, learning through service is critical to medical education. And 3, medicine should be a force for social justice. Next slide.
Now, building off of our first principle, community at the center, we propose fostering a close partnership with community leaders to identify areas of need and develop programs to address them. Required longitudinal service learning projects will also place community engagement and learning at the center of medical school education. Next slide, please. Now, for our second core value, education through service, we propose streamlining basic science curricula and reallocating time for service-based learning. We also believe that students should be given dedicated time during clerkship years for service-based learning to promote continued involvement across all 4 years of medical school. Next slide, please. And finally, medicine should be a force for social justice and social good. We propose a course-based academic introduction to social determinants of health taught by experts in the field. We also propose the creation of a dedicated Year 3 Social Determinants of Health seminar to include reflection time during the clerkship year to discuss real-world clinical applications of these concepts, drawing from student experiences that they have had on the wards. And lastly, we believe that expanded anti-racism training should be offered to all medical students. Next slide, please. So we just wanted to thank the organizers for the opportunity to share our thoughts and for everyone being here tonight. And also appreciate our wonderful partners at Einstein and fellow students who have made all this work possible. So thank you.
Thank you so much for those outstanding presentations. I want to say that I am thoroughly moved, touched, and inspired by your voice, your perspectives, and what your call to action is. And I want to just, before we transition to the breakout sessions, in the name of outstanding author and advocate James Baldwin, not everything that is faced can be changed, but nothing can be changed until it is faced. And I will acknowledge all of you on behalf of your peers for calling it out and naming it and heading it on full steam ahead. So thank you. So we have just about a half hour remaining in our session today. These are the breakout sessions we invite you to Zoom into. These are the 5 topics listed here. And you can join us right now. In fact, all of these sessions will be student-led. I want to thank all the presenters once again, and thank you for your attention and being with us today.